So Syringomyelia in Chiari patients, when is a good time to drain the syrinx? And let's see, more importantly, should it be done more often? And this is something that, I'll be honest with you, I don't have a right answer. This is something that we've been discussing for a long time. And over the next 20, 30 minutes, we'll talk about what has been done in that direction and hopefully where we're heading. So why is there syrinx in Chiari patients? This question has been bothering neurosurgeons for many years. And there are very sophisticated theories in that regard. You may or may not know this, but back in late 1950s, Dr. James Gardner, who was working in Cleveland Clinic, came up with his very interesting explanation or why this fluid accumulates inside the spinal cord and why people form what we call syrinx, which essentially is a fluid-filled cavity in the area where it does not belong. There's really no fluid cavities in the spinal cord in normal situation. So whenever there's a collection of fluid, we call it syrinx. Syrinx essentially syringe, the cavity, a balloon. And when it happens to be in the spinal cord, which is myelin, we call it syringomyelia. The syrinx can also happen in the brainstem, in which case it's called syringobulbia. But here we're just talking about syrinx associated with Chiari malformation. So Gardner and Angel wrote a paper in 1958 about what's called water hammer theory. And people like that. There were certain weak spots in the theory. It didn't cover all the cases. And so Bernard Williams from United Kingdom, 10 years later, came up with his own theory, which essentially modified the Gardner's approach, and was calling it the suck effect. So there's a sucking action that creates fluid accumulation inside the spinal cord, which was more or less more comprehensive in terms of explaining the mechanism. And then a few years later, Ball and Diane came up with their idea, and it was very much supported by Dr. Oldfield, who was working in National Institute of Health in NIH. And that theory has become more commonly described. As a matter of fact, one of the biggest proponents is Dr. Heiss, who we heard yesterday from in his Zoom presentation when he was talking about arachnoiditis. So Ball, Diane, and Oldfield theory has to do with perivascular cerebrospinal fluid dissection. So the fluid gets into the spinal cord through natural channels around blood vessels and accumulates inside because of this obstruction of flow and continuous pulsation. And then Dan Greitz out of Karolinska Hospital in Stockholm, Sweden, came up with his idea about changes in pressure inside and outside of the spinal cord. And pretty much each of this theory kind of expands on the previous one. And since now we have multiple explanations, we know for sure that probably neither of them is completely right because, first of all, every patient is different. And secondly, each of these theories have certain weak spots which we cannot fully explain. But this is an illustration that came out in the Journal of Neurosurgery by Dr. Heiss and his team, essentially explaining how things work. Because if you look at this is a normal situation when tonsils are not herniating. That's a brainstem, that's a spinal cord. The arrows show how the fluid runs during systole when the heart contracts and during diastole when the heart relaxes. So you can see the fluid goes normally down and up. And when you have Chiari malformation with tonsils herniating into the spinal canal, there's obstruction here and fluid has nowhere to go. So when the heart beats, the fluid goes around the spinal cord, squeezing it and getting into the center of the cord. And when the heart relaxes, the fluid goes up, outside and inside the spinal cord, and that's how the syrinx forms. And then when you do surgery, the postoperative picture shows us now the flow is established again, there's no obstruction, and the syrinx disappears. So that's great on a picture, but may or may not happen in real life, and that has been an issue. Interestingly enough, we talked about it all the time, but there's finally found something printed in the scientific literature which deals with very interesting phenomenon that the size of the syrinx does not correlate with clinical symptoms. And this Dr. Klickamp out of Germany, who's published a lot on Chiari and Syringomyelia. And so he says it's always puzzling that patients may harbor a huge syrinx and yet have just minor symptoms, with exactly opposite observation for some smaller syrinx cavities associated with major neurological deficits. And that's a reality. We see patients all the time with large syrinx and non-neurological symptoms, and with tiny syrinx and disabling deficits. So this is an example of what we expect to happen. So as you can see here, this patient has large syrinx, has Chiari malformation with obstruction of flow at the level of foramen magnum, which is opening in the bottom of the skull. So this white signal inside the spinal cord, that's what's called syrinx. That's Syringomyelia. So now the patient has surgery. This bone gets removed, and that's after surgery. Now you see there's no bone here. There's plenty of space. Spinal fluid is running. Fluid is white. Spinal cord is gray. And what happens as a result? The syrinx is gone. So all this white thing inside the spinal cord suddenly disappeared. I mean, there's still some little bit left, but not as much as what it was before. So this is hollow syringomyelia, like entire spinal cord is blown up. Pretty much goes almost to normal after the surgery. That's what we expect to happen. That's usually happens after surgery, and that's a standard type of treatment. But I'll tell you the case, just abstract case, pretend it's a real person, because there are obviously more than one real person with this type of history. And this is somebody who comes for evaluation right in the middle of COVID when we're trying to do telehealth, see some people in person. But this patient comes, and what happens? She was diagnosed with Chiari and Syringomyelia back in 2008, quite a few years ago. She was definitely obviously younger at that time. And the symptoms she presented with were headaches, neck pain, tiredness, nystagmus, abnormal eye movements. So what happened? She had surgery. Because when you have this type of picture on MRI and this type of symptoms, you have an operation in 2009, and it remarkably improved her condition. The syrinx almost disappeared. The symptoms have improved, almost resolved. And then 8 years later, she gets another MRI, but not for fun, but because she started having new symptoms. But this time they're different symptoms. There are pain and numbness in her arms. The gait gets affected. So 2017, she goes for an MRI, and MRI shows that the syrinx came back to pre-op levels. So as bad as it was before surgery, despite the improvement, it went back. But now there's good flow at the foramen magnum, at the bottom of the skull, and she gets cine MRI that shows the fluid flowing. And therefore, the doctors say that she doesn't need any intervention. So what happens next? The symptoms actually get worse. The pain, numbness, now she needs assistance with ambulation. But MRI looks stable. MRI is not getting worse. And therefore, once again, she's told that she does not need any treatment. So finally, she comes to see us. We do surgery. We intervene on syrinx. And her symptoms improved, but only partially. So they did not go back to normal. Some symptoms persisted despite quite successful treatment. And that's the point of this talk today. So should we intervene earlier, or should we really wait for patients to get worse until we do something for it? Now, we're not the first ones asking this question. This paper came out 25 years ago out of Japan, and they just compared patients who had two separate treatments. One had foramen magnum decompression, and one had a shunt, draining the fluid from the syrinx. So they showed these pictures. 2 months after foramen magnum decompression, you see the syrinx is gone. And then this patient had surgery to shunt the spinal fluid out of syrinx. 11 days after surgery, significant improvement. From this large black spot here, there's only shadow of black. So significant improvement. Both surgeries work. Questions which one works better. Now, they compared quite a large cohort of patients. They had 33 patients who had decompression and 37 patients who had shunts. And both groups improved quite a bit. But to everybody's surprise, the improvement in the decompression area was 61, 72%, and in shunt group was 85 and 95%. So it was significantly better. Now, it wasn't randomized studies. It wasn't like they chose the patients based on like random assignment. They had their rationale for this, and looks like it worked well. So this is not a high level of evidence. But this is something that showed that both treatments are valid, and one may be slightly better than the other. So therefore, we have an algorithm now. We use something, and we frequently use algorithms in surgery because we want to know what to do in each situation. And the algorithm is very simple. You get a patient with Chiari and Syringomyelia, you do surgery. And the surgery involves decompression at the level of posterior fossa in the back of the head, called foramen magnum decompression. And then you get MRI in a few months, and then you can 3 options. You can see the improvement or resolution of the syrinx. You can have persistence of syrinx, meaning there's no improvement, but it's not getting worse. Or you can actually see some worsening despite surgery. Now, if everything goes well, obviously you leave the patient alone. If things don't get well, you follow them up and you get clinical evaluation. Are they stable or getting better, or they're getting worse? Those who are stable, you continue observation, you get MRIs every year or so. Those who get worse, you consider shunting. So that's the algorithm we have right now. Now, not everybody subscribes to this. Obviously, there's as many opinions as there are surgeons. But this is kind of general party line. That's what we do. We treat the patients, we follow them up, we observe them, we decide based on how they progress, and then we make decisions. And there's rationale for this, because nothing is perfect. There's pros and cons for every treatment. So question is, what kind of shunt procedure is better? I mean, we already talked about open surgery and decompression and multiple conferences before and now, but we haven't talked much about the shunts. So it turns out you can shunt the fluid in many ways. You can shunt the fluid internally from the spinal cord to the spinal fluid around it, or you can shunt it out to the peritoneum. It's called syringoperitoneal shunt or syringopleural shunt. And I know some of you are well familiar with that because you either had this surgery or were suggested to have this surgery. So I'm not telling you something you haven't heard before. Our colleagues out of Florida wrote this nice summary. They analyzed all the literature in the world published until 2021, and they went through all this information about all these kinds of shunting, syringosarachnoid shunting, syringoperitoneal, syringopleural, and they came up with about 20 different papers, hundreds of patients analyzed. And essentially their conclusion was that all three techniques are being used. So people described each of these techniques in multiple papers. So what's the chance of clinical improvement based on this? They analyzed that too. And they came up with an answer that pretty much all three techniques improve the patients quite a bit. There's about 60% chance of improvement with syringosubarachnoid shunt. There's about 64% chance of improvement with syringoperitoneal shunt. There's about 70% improvement with syringopleural shunt across a series. So some did much better, like 100% improvement. Some did not, 20% improvement. But on average, when you summarize the entire world literature, the results are pretty good. So all three techniques worked. So the question is, why don't we shunt syringes more often? Why not everybody gets offered this surgery? Why don't we do this? Well, it turns out, just like it's expected, that the shunt surgery has its own cons, not just pros. And one of them is that this surgery may not be sufficient and patients may require reoperation. Now, which surgery is worse? It's hard to say. There are 13% of syringosubarachnoid shunts that require reoperation. There's 28% of syringoperitoneal shunts. There's 10% of syringopleural shunts who required reoperation. So it means they had the second surgery for the same problem. They also had some deteriorations. So yeah, there were a majority of patients who improved, but there were some patients who actually got worse. And which group did worse? It's hard to say. 13% in this group, syringosubarachnoid, 13% in syringoperitoneal, 10% syringopleural. So pretty much on par with each other. And then there were complications, because every surgery carries the risk of complications. So people analyzed that too. They came to the conclusion that syringosubarachnoid shunts had 23% complications. Syringoperitoneal shunts, when the fluid gets shunted into abdomen, had 39% complications, and pleural had 25%. So neither of them was perfect. They are equally ineffective and dangerous, even though vast majority of patients improves. And these are just illustrations. You can see that's a patient who has a syrinx, already had Chiari surgery, there's good decompression here, there's plenty of room, and there's still big syrinx present here. That's where the cut is made, and you can see on the picture that most of the spinal cord is occupied by this white signal, which is fluid. It doesn't belong there. After surgery, after the shunting, you can see the same level cut. Now there's very little of white signal here. Majority of fluid is drained out. And you can see the entire length, if you cut through this area, you can see how long the syrinx was here and how narrow it becomes after the operation. And it's not just that. There's also the same very patient has a different syrinx a little bit lower in the cervical canal at level of C4, C5. And after surgery, that fluid accumulation is gone. So all of this, as you can see, at least radiographically, does improve with surgery. I mean, that's a different example here. See, once again, the patient already had surgery. There's good decompression at the level of the posterior fossa, but there's large syrinx. And after surgery, that syrinx is pretty much gone. So this entire circumference of the spinal cord filled with spinal fluid now is completely collapsed and the fluid is gone. So different person, different age, different everything. Now, that previous one the patient had persistent syrinx, meaning it did not go away with surgery. This patient had recurrent syrinx, so this patient syrinx went away and then came back. So we see it often, and you can see sometimes you can drain the fluid completely, and sometimes there's still a little bit left. And that has to do with the anatomy of the spinal cord. So not everybody improves to the same degree. Now, if you look at literature, there's a lot of explanations on how the procedure is done. And this is one of the recent papers just from a few years ago, 2017, and you can see that the incision is made on the side of the spinal cord. It's called dorsal root entry zone. It's called a K-tube, the small device that gets inserted into the cord. And you can see dramatic improvement from large syrinx to almost no syrinx at all. How does it work? I mean, that's what's called K-tube. It's a tiny plastic piece with a tube coming out. And that's your actual surgical picture. You can see that's a spinal cord. There's an incision in the cord. And that's a tube gets inserted. That's a tube coming out. So that goes into the spinal cord and sticks out. And that's how the fluid gets drained. That's a K-tube surgery done in 2017. Now, 40 years ago, 1984, that's a group in UCSF, published their experience. Now, at that time, they called what T-tube, because slightly different shape. And the MRI was just starting, so they could see the pictures. But most of the time, patients would get myelograms and CT scans. And you can see this white signal, these bubbles. That's actually contrast material inside the spinal cord. So they did this. They used the T-tube. And they say it works quite well. Now, a few years later, our group from Japan, that was in 1999, showed a very similar approach. They did very small opening in the bone, and they would put a catheter in the cord to treat this Syringomyelia from this to this. Quite impressive improvement. But you can see how huge the catheter is. And even though the catheter is quite small, for the spinal cord with tiny nerve roots, this large catheter may be the reason why the patients had all these complications. So what we started doing, instead of using this, we started using much smaller things, discovered that there's actually a lot of medical equipment that is being used off-label. So these are myringostomy tubes. And myringostomy tubes is something that people use for middle ear in kids and adults. When you have ear infection, they make a small opening in the tympanic membrane, in the drum, and they put tube there just to get the fluid out so the ear doesn't hurt anymore. So these myringostomy tubes come in two shapes. One is called T-shape, and one is just a button. And it turns out that they are remarkably well suited for syringous arachnoid shunts. So how does it work? That's actual surgery. So that's a spinal cord, and you can see this hole in the spinal cord, and you can see the whiteness on the back of it. That's a syrinx. That's a cavity inside the spinal cord, and the blue thing is a tube that we put in to keep this hole open. Because when people do surgery, just open the syrinx and drain the fluid out, and then they close everything together, that hole tends to seal, and the fluid accumulates again. So to keep the hole open, we put these tiny shunts, and sometimes we use this T-tube, and sometimes we use this button. But keep in mind, this is a procedure when we do very small opening. We do not put any large catheters, and we put, essentially, as you can see, everything is dry and clean. There's no blood there. And that would allow us to minimize the scar afterwards. Now, how does it work in reality? And you can see here, that's a patient who had surgery for Chiari with syrinx. 2015, the syrinx is almost gone. 2020, syrinx came back. 2021, after surgery, now we put a shunt here, and you can see that the syrinx has collapsed. So does it last? I mean, here's a different patient. Once again, original surgery in 2015. No, 2015 was diagnosed. 2016 had the surgery for Chiari. The syrinx is gone. 3 years later, the syrinx starts coming back. Nothing is done. 2 years later, after that, 2021, now syrinx is quite large and the patient is symptomatic. So we're doing surgery, we're putting the shunt here, and 6 months later, it's still gone. So does it work for every patient? It's hard to say, but it definitely works for some. And I guess the treatment here, the key part, for all these procedures is to keep things clean and make incision as little as possible. Because as you heard my colleagues yesterday, when we discussed this, they are very reluctant to cut the spinal cord. And they are very reluctant to create additional damage to the person who already is damaged by the underlying condition, which is very much understandable. We really want to avoid more risks and more even potential for injury. So should we continue doing it? Should we not do it at some point? It's hard to say. But what we're suggesting is just to look back at our algorithm. And instead of waiting for 6 and 12 months just to see how things are, get imaging earlier. If you wait for 3 months and you see that things are not improving, maybe that's time to intervene. And probably even more controversial is to not wait for patients to get worse, but act on radiographic findings because they were symptomatic to begin with, and therefore act on the radiographic findings before clinical worsening occurs. And that's probably the most controversial part, because we do not want to do any preventive surgery. But at the same time, we unfortunately are well aware of the fact that once things get worse, they are usually irreversible. So when we already know about the problem, and when we know that there is something that most likely will get worse in the future because it has already recurred or it has already not responded to standard treatments, so maybe it's worth taking a risk, worthwhile to do the surgery, kind of bite the bullet, and give the patient chance of remaining stable rather than wait for them to get worse, because as experience shows, once patients do get worse, the chance of improvement becomes much lower. Because like I mentioned yesterday, the surgery is done to stabilize the condition, to avoid further progression. Now, sometimes people do improve, and we're always happy when this happens, but we don't expect this to happen. We do surgery not to improve the patient's condition, but we do surgery to prevent further deterioration. So if you really think that there will be deterioration, then it makes sense for us to do something maybe more aggressively. And that's something that we will have to discuss more and more, and perhaps do some studies to see if this is a valid point or if it's a completely crazy approach. So that's not the entire story, because remember the talk yesterday about arachnoiditis, how much scar tissue can be there? So what happens when you have a patient like this who has a syrinx which persists despite treatment, and there's local tethering and there's arachnoiditis? Now you can still try to do the surgery, and that's the same shunt that I showed you earlier, but you see how scarred things are around? So this shunt in this situation is much less likely to work, unfortunately, because when we drain the fluid from inside the spinal cord to the outside, chances are it will not absorb because of all this inflammatory reaction in the arachnoid tissue. So the same approach we recommend for Syringomyelia from Chiari may not necessarily work in Syringomyelia due to arachnoiditis and tethering. Now, we still do it because if we try to untether cord which is blown up from inside, untethering may not work. There's just too much contact between the cord and the arachnoid membrane and dura. So sometimes we would do dissection, we would drain the syrinx, and hope that by collapsing the spinal cord, we can avoid retethering. So, back to where we started. When is a good time to drain the syrinx? Should it be done more often? Well, the honest answer, I don't know. But I think the surgeons and the patients should be open-minded about this and consider this as an option in very specific circumstances. Thank you very much for your attention.